Thank you very much. Good afternoon. This committee on appropriations is reconvening the fiscal year 2015 budget hearings. We began today's hearings with the Department of Education at 9:30 this morning, and we're now here to discuss the budget request of the Guam Memorial Hospital Authority. I think I'll try to remember this time to try to frame this hearing. The FY2015 executive budget request, Bill 269, that was submitted by the governor for the fiscal year 2015 included a total of $17,188,884 in appropriations for the Guam Memorial Hospital. This represents an increase of only $4,011 increase of the 2014 appropriated levels. The appropriations made to GMHA represent local subsidies to the GMHA and not its main source of revenue. The GMH's main source of revenue is from patient service revenue. And again, for 2014, the authorized level was $17,184,873. And the governor's executive budget request, Bill 269, is $17,188,884, or a $4,000 increase. I just wanted the public to understand that what we appropriated last year and what the governor is requesting is a difference of about $4,000. As a result of the increase in the projections for business privilege tax collections, the GMHA Pharmaceutical Fund, which is 4% of BPT, increased by $1,040,553, or 11.17%. There was a corresponding decrease from the Healthy Futures Fund, unfortunately, of $1,036,000, or a 26% increase, which offset the increase in the pharmaceutical funds. In FY 2014, Public Law 32-68, General Appropriations Act for FY 14, authorized advance appropriations for FY 2013 expenditures in the amount of $10,529,959, from which $7,635,619 could be taken in certain FY 2014 executive branch line agency appropriations, and $2,894,340 could be taken from FY 2014 general fund appropriations to the GMHA. Additionally, the executive branch was provided transfer authority totaling $22,938,192 for FY 2013 expenditures from 2013 unallotted and unencumbered 15% reserves and a 2% reserve. On January 31st, 2014, the government of Guam refinanced the existing GMHA line of credit in the total amount of $25 million, which is funded by the Healthy Futures Fund and Compact Impact Funds. As I understand it today, the GMHA FY 2015 budget request is for a total of $44,640,000, which is an increase of $27,445,127, or 159%, 160% increase over 2014 appropriated levels. As we can see from this increase, there appears to be confusion as to the funding levels that the GMHA believes it received or will be receiving in 2014, according to Public Law 2032-28. We'll go through that later, but let's hear your testimony. I just wanted to make sure that it was understood that this last year was $17 million and you're now asking for 44, and we need to get that clear.
Okay. I just have an opening statement, if I may read it, and I apologize for my voice, which is just getting over. First, Hafaday and Buenos, Vice Speaker and distinguished senators and guests, thank you for inviting us to this hearing. GMHA GMHA's trustees and management team look forward to speaking with you about Guam Memorial's fiscal 2015 budget. As you know, the hospital's mission is to provide high-quality, safe care to the people of Guam, regardless of ability to pay. As our essential partner, your support is vital to ensure success of this mission. We want to thank you for the legislation initiatives in support of GMH that you have supported this past year. We also want to recognize the late Senator Ben Pangilinan for his leadership and steward in the pursuit of good government. In the current fiscal year, ending this September, you have legislated a total of $20.7 million, including general fund appropriations allocated to GMH in support of its mission. We sincerely appreciate this much needed assistance. As we will discuss, GMH has not received this total allocation. In fact, out of $20.7 million, to date, GMH has received a total of $6.6 million this fiscal year, with only 2 months left in this fiscal year. Last week, you heard the OPA public auditor, and we responded to the Senate's questions about Guam Memorial Hospital status as a going concern as a result of not being properly funded once and for all to accomplish its mission. We identified many areas of concern, including adequate budgeting, appropriations for and funding for Medicaid and MIP, adequate appropriations and funding for Medicaid and MIP to reimburse GMH for its costs, whether or not Medicare proceeds to its rebasing. A source of recurring funding dedicated to the reimbursement of GMH for the cost of uncompensated care it provides, such as a customs user fee, was one such idea we discussed and threw out there. The bottom line is, I'm sure there are other ideas, but a recurring source of revenue for this purpose is needed. Here is our reality at GMH. GMH is operating, I'd say, on a shoestring budget, or rather, on a frayed shoestring budget. Our bank account averages around or under $40,000. Because both government insurers and local insurers are not adequately reimbursing GMH for the cost of its services it provides, for the 9 months ending June 30th, GMH lost $22.2 million from operations. This is not from hemorrhaging. This is not from uncontrolled expenditures going out the window. This is, as I like to call it, due to hypovolemia. And those of you who understand medicine know that that means you don't have enough lifeblood in you to function properly. So that's, again, there's no secret, or the reasons for this are pretty well known. Guam Memorial's liability to vendors was $13 million before reducing the payable to revenue and tax. The hospital's expenses are greater than cash flow, leading to ever-increasing liabilities to vendors who provide supplies, services, and equipment to the hospital. Through June 30th, GMH incurred $20 million of charges for care to self-pay patients, of which $14.2 million was for inpatient services. These charges annualize to $27 million, but the actual cost to provide service is much greater. We've received $3 million from self-pay patients, but most of these payments go towards the cumulative $180 million due from uninsured patients. The hospital has begun to expand its clinical services by offering things like epidurals, expanding orthopedics, joint replacements, expanding neurosurgical capabilities, adding cardiology, telemedicine, various outpatient services, and urgent care. The hospital cannot fully establish these initiatives since it lacks the funds necessary for the capital improvements to sustain them. Unfunded mandates have also placed an additional onerous burden on the hospital's finances. So what are we doing? What is GMH management doing? Management provided many examples of its leadership. I mentioned that the hospital submitted its application for Medicare rebasing. I'm awaiting word from Washington as we speak on a meeting to travel to DC to meet with CMS to hopefully favorably close this initiative. We are finalizing contracts for charge master, collection agency, outsourced coding and billing and collections. RFPs are in the works for outsourcing lab, reference lab, radiology, cafeteria and parking are also in the works. Space use at SNU. An RFP to outsource anesthesia services is also under development. GMH met with insurers on Wednesday to negotiate new reimbursement contracts. The old contract is 6 years old. GMHA's fees are 15 years old. GMH is pursuing negotiations with insurers based on new methodologies of per diem rates, replacing the decades-old antiquated way GMH has been reimbursed for services. This initiative has been well received by the insurers, although, of course, there is a difference in the opinions on the rates that GMH is requesting. We are still in negotiations with insurers. GMH plans to resubmit its fees to the legislature. If the 2000 law had been followed, GMH's fees would now be 90% higher than they are. As it is, we are requesting an average of 50 to 60% increase to compensate for this gap. GMH cannot meet its mandate while shouldering further unfunded mandates, and I will elaborate. We still owe $1.5 million for the incremental wages promised in May 2013 when the wage rates were unfrozen. The annual cost to implement the HAY plan will be $4.1 million. Once the non-clinical staff receive the remaining 50% they did not receive in February. With the exception of $125,000 received on February 14th, GMH did not receive any additional funding. Under the HAY plan, employees are paid on a step basis with 3.8 annual increases. There is no annual funding from year to year. The hospital's contribution to the retirement has increased from 18.6% in 2000 to 30.09% in 2013, with the hospital paying $8 million more than necessary because the 30.09 exceeded the 5% corporate match contributed to the employees. The hospital's cost for medical health insurance has increased 40 to 50%, while hospital fees have been stagnant. The hospital must pay generous annual leave and sick and other benefits that dramatically exceed other areas of the workforce. In short, what can the legislature do, and what are we asking? Reimburse GMH for its cost as determined by the Medicare cost report that is prepared each fiscal year. Medicaid and MIP should settle the reimbursement going back to the beginning of the year and correct reimbursement for the current year based on Medicare's changes. Medicaid and MIP should match Medicare reimbursement if Medicare adjusts reimbursement for prior fiscal years. GMH received an additional $1 million from Medicare for fiscal 2012, but Medicaid and MIP did not provide incremental funds and did not match it. Medicare and MIP should increase its funding for professional services provided by Guam Memorial physicians and providers, which have not been increased in some time. Medicaid and MIP should not deny care and pay for patients or members who seek care in the emergency department, even if public health clinics aren't open or appointments are not available. GMH has been denied payment by public health for services rendered for patients that have been to the ER. Create legislation that automatically releases the remaining 40% related to the gaming tax revenues, so we can use that for operational purposes. Develop a funding source with proceeds attributed to Guam Memorial Hospital used for subsidizing self-care, as I mentioned, and funding capital expenditures. Legislate processes to ensure funds for serving patients from other Pacific islands. Ensure Healthy Futures funds are designated for the hospital's bank financing not related to compact impact funds. Remove the legislative restrictions on hospitals' fee increases. Increase the pharmacy fund from $9 to $15 million, with the full funds allocated directly to the hospital to be used for critical capital improvements and other needs, not siphoned off and put into Medicaid, where GMH never fully realizes the full amount of these funds. Of the $9 million allocated, GMH has only received $2 million of those funds. Release GMH's obligation to pay the full 30.09 contribution to the retirement fund. In fact, to balance our fiscal 2015 budget, GMH has reduced its contribution to saving $5 to $10 million. Reverse the hospital's liability to DRT against funds that Guam owes GMH. adjust or relax procurement rules and regulations for contracts and requests for proposals and pricing quotes. For instance, GMH should not have to require an RFP for purchases under $50,000. And fund the balance of capital improvement expenditures estimated at $4 million for projects such as obstetrics and women's care. In closing, we look forward to working closely with Guadalupe, the legislature, and all key stakeholders to finally properly and once and for all fund GMH so it may meet its mandates and stabilize its finances. We thank you very much for your time, and we look forward to a discussion on our recommendations, proposals, and initiatives.
Thank you. Can we get a copy of that?
Yes.
So that you can get that and copy for at least for the three of us.
Is June here?
No, ours.
No, I know. June brought some copies. Is June here? Right, yeah, okay. You can take it off of here, but she has clean copies, so just bring me copies.
Well, here, just take it and we'll, so that, I'll have the chair ask, your oversight chair ask the first set of questions, but I just wanted to get one thing clear. Did I hear you testify that the amount that we've appropriated, the 20.6 total?
7.
20.7 that's been appropriated, you've received to date 6.6?
That's correct.
As a clarification of that, yes, you provided $10 million through various types of appropriations, and then in the special legislation that you mentioned, the $7.5 million and the $2 million each, that was additional funding that was included in the bill. We received in September of 2013 $3.6 million, but during the year in process, fiscal 2013, we have received $6.6 million. So from a 2014 standpoint, we have not received the $20 million. That's a combination of both your special appropriations and the existing appropriations that we have.
And what efforts have you made with DOA, BBMR, and Guadalupe to release that remaining 14?
We have talked to them. I've been directed to BBMR to talk about funding and what's available. Also, as you know, from the public hearing that we had in early July, we talked about what funding we need for public health for the balance of the year too. Whether it's special funding from the $10 million that was appropriated by the legislature, for which we are grateful, or adequate funding for public health, we don't have access to those funds.
But there's still 14 million that hasn't been received by the hospital from.
For 2014, correct. 3.6 million was received last year because, as you know, during July through September of 2013, we had a shortfall of funding from both public health and from Medicare, and that 3.6 million was received in September to help cover our payroll. But as far as 2014, we have not received those funds, no.
Can you provide this committee with copies of the correspondence that you've had or emails that you've had with Guadalupe asking for the additional 14 million?
I can provide what I have on that, yes.
Okay, because it just, I
believe that the $10 million was discretionary, drawing out of certain funds, but I do not have access to, to move the monies around in Guam Executive to make it available to Guam Memorial.
that 10 million that you're talking about, as I was looking at your appropriation, that's the legislative mandate. Is that correct? In Chapter 6 of the Appropriations Act 31-68, we provided $7,637,000, and then there was General and Special Revenue Fund in Chapter 3, Part 1 of $2,895,000.
That's correct.
And you've only received
We received 3.6 in fiscal 2013 as an advance, if you will, against 2014. But once again, we had a significant shortfall because of underfunded public health in 2013, and these funds were actually shown as an advance against those appropriations, but nonetheless, we did not receive them in 2014 to help with 2014
you're asking for an additional $4 million in your budget right now, under legislative mandate, correct?
Well, we have various things. I have my own statement to read as far as the specificity of the various line items, and I can just summarize that. But
Okay, then let's hear yours, and then we'll continue with the questions.
thank you. And Vice Speaker and Senators and the public, appreciate the chance to speak on behalf of Guam Memorial, the board, Mr. Bergen, myself, and the managers who are here supporting us. The letter that I've given to you specifically provides detail relative to Mr. Bergen's comments regarding funding for Guam Memorial. And in the three-page document that you have, I have identified not only the chapter, the part, and the section and line item of funding that we are requesting for 2015. The one thing that Mr. Berger commented, and I want to emphasize as we have had the conversations about Guam Memorial as a going concern or what its funding requirements are, is that we are doing our best to balance the budget. We are balancing the budget. We presented a balanced fiscal 2014 budget. We have done the same thing for 2015. But there are certain requirements that must be made. We are working on Medicare to get cost-based reimbursement. We also are looking for Medicaid and MIP to provide that, whether or not Medicare goes ahead. But as you look at the line items that we're talking about, we are wanting to make sure that public health is funded adequately for Medicaid and the MIP programs. For instance, if we assume that MIP is fully funded and that 30% of their costs are going to Guam Memorial, if we have a budget of $10 million, then we would assume that MIP should have a budget of $30 million using that simple arithmetic. But we don't know whether, in fact, MIP has $30 million. We've talked about $15 million. And at the public hearing, Ms. Archangel said that it was actually much less than that as far as actual MIP expenditures. Nonetheless, in our budget, we had projected $10 million. We have the same thing for Medicaid, where we had on top of page 2, we have budgeted $27 million for Medicaid reimbursement. If that's 30%, 35% of the total Medicaid budget, then I would expect them to have $82 million appropriated. Now, whether I have not sat down with my counterpart at Edelloop to determine whether or not they have actually appropriated those funds. But as you look through all of these line items that we have here, we are identifying what the needs are, not only for Guam Memorial, but what has to be appropriated in Gov Guam and all of the agencies to ensure that Guam Memorial is adequately reimbursed for its services. So we talk about the pharmacy fund with a change of instead of 25% going to the pharmacy to GMH net, we talk about 75%. You talk about the pharmacy fund going up for 11.17%. That's great. But on the other hand, it's taken away, so we're at a net sum zero. That doesn't work. We are talking about, you mentioned going from $17 million to $40 million. We need support for our services to the self-pay and the uninsured, and also to support GMH for unfunded mandates that were mentioned. We talked about $4.1 million for the Hay study. We talk about $1.5 million still outstanding from the increment. This list on pages 1 through 3 goes line item by line item, agency by agency, as to what we would like to, what we believe should be in the Gov Guam budget for fiscal 2015. Also attached to that document are letters that were presented to the late Senator Pangilinan July 30th, and also to Senator Lim Tiaco in August, relative to what was needed for fiscal 2014 funding. Once again, we had a balanced budget. We requested funds. We said there's a shortfall. We need it. It hasn't happened. And so we're faced, as Joe mentioned, a
much, Mr. Chairman. Thank you guys for being here today. Before I have actually only 3 questions, but the first one is, I know last night's board meeting, there was an approval of a write-off of about $178 million. Can you update this committee on what that was about?
Thank you, Senator. Yes, we have, if you look at our financial statements for the month of June, and as you look at all of them that are posted on our website, you will see that we have total receivables of $251 million as of June 30th. Of those, $182 million are from self-pay and the uninsured. Now, Guam Memorial is proceeding with a conversion to a new accounts receivable system, a new patient registration revenue cycle system scheduled for August, and from a conversation I had this morning, will probably be in September. But as part of that, we are moving from what we call our AS400 system to an optimal system. It's through our software vendor, NTT. Part of that is not only changing our processes and procedures to go from a 25-year-old software system that is no longer supported to a new software system with processes that are current, but also they want to take all of our existing information, patient information, payer information, and migrate that also to the new system. Long story short, it is not appropriate to clutter a new computer system with over $175 million of receivables that are over 4 years old, or that haven't been filed, or they haven't been paid, or they've been denied. So the resolution that the board approved last night was to say, yes, we want to clean up our receivables as we migrate to the new system, and that is going to reduce our receivables, gross receivables, not collectible receivables, gross receivables, from $251 million to approximately $66 million. And of course, this changes daily as we submit new claims and get payments, etc. But the bottom line is to clean up our receivables to reflect what is truly receivable as of whatever that conversion date is.
And Senator, as you know, this has been recommended by auditors for years to clean up the receivables, and as far as what's truly collectible and what's not truly collectible. And this is what we are doing now, is once and for all finally cleaning off the books and making it into a number that is truly that is collectible less than 4 years old. But it also doesn't mean that the number we're cleaning off is not going to collections, Alan, right? So the number, the amount, even though we're cleaning off, we're moving it over. Really, it still will go to collections. But as we determined, that money is really not collectible, and it's been on the books, as you know, for a long time.
And let me add one more thing to that too. Thank you. We are going to be we are finalizing the contract with the collection agency, and we hope to, we will transfer funds from our receivables to the collection agency to follow. Some of it's appropriate under credit laws, others isn't. And the ones that aren't, or if we haven't billed it correctly to the insurance companies, we are removing it. We cannot pursue payment from individuals if in fact we have not followed our own billing processes, which is why we are also negotiating a contract to outsource all of our coding and billing. But the bottom line is that it's not only things that are over 4 years old, but also things that I might have not filed to Medicare a year ago, and so I've missed my filing. I have to write that off. And the bottom line is I'll have $65 million gross, and in the meantime that I will be looking at reconciling with the local insurers and with public health as to what that balance really is.
Thank you. Which leads me to the follow-up question of the business office, right? We've known that we can, everything that Joe spoke about, what needs to be funded, where the funding needs to come from, we can do all of that. But the heart, your lifeline in the hospital is the business office. And when we discussed this a year ago, when you guys first came on board, we talked about that's where the concentration of the efforts need to be at, is to boost up your business office, get their billing and collections up to par, which you say now that you're almost there. You're sending a contract down. Is that what it is? Where's the process? Where are you at in the process of your billing and collection RFP?
We did start the process last fall as far as making the decision to outsource the coding and billing. We have released the RFP
hoping that this will really, get off the ground, because we've been talking about this for 3 years, even prior to you.
It is,
about
in
billing and
fact. But in
collection.
fact, we also have hired temporary coders or billers, right? And you can explain to the senator who we have working for us right now at this moment, that are helping us in Washington on the other side, going after Medicare claims already. So it is already in motion, and we have the vendor, and we are now closing the contract. So this is going to happen. I know it's been a long time, but it's been a long, arduous process, and it's a very complex RFP, and it was a very complex negotiation process. But nonetheless, we are now there.
Yeah, and so that that's the reason why you had to write off that huge amount, because as you say, you can't go back after a year to Medicare. With insurance companies, you also have a time frame, a timeline, right? That you can't go back and bill them. But there's really no protections now for the self-pay, because the self-pay, there's no timeline. Even after a year or two that you find out that you didn't bill them, then you can go back and bill them, right? So is that happening now, or is that part of the write-off that was just approved?
Well, thank you. There are several parts or components to your question, so let me try and answer them or clarify. You're right when we talk that we cannot submit claims to Medicare, Medicaid, and MIP within 1 year. In fact, when I look at the $15 million that I have receivable from Medicare right now, and as Joe said, we have 2 Medicare coders who are working off-site to help GMH collect that money. But they've identified $7 million that's past timely filing. I cannot go back, but they're going to be looking, they're going to be researching to see if in fact we can submit those claims. I will digress for a moment before answering your question about the self-pay to say that Mr. Verga, Dr. Seidel, Dr. Lazama, and myself have been working very closely with the medical staff to try and get medical staff to do what they're supposed to do, which is documenting their work in the medical records. There's nothing that irks me, for lack of a stronger word, than taking 60 days to get a claim out the door because I don't have operating reports, I don't have discharge reports, I don't have the documentation I need. And once again, we are trying to persuade the doctors to help the hospital. But in the new contract that we have, that we presented on Wednesday, we asked that the insurers accept 180 days for us to submit claims, so we don't run out of timely filing. Relative to what you said, you're right. If I submit a claim to an insurance company and they say, well, this is really self-pay or a co-pay, at that point in time, I can turn around and charge the individual. We've talked about blood products, for example. If I'm charging $700 for a unit, and let's say I get 4 units, that's $2,800. When I submit the claim to the insurance company and they in turn return the remittance, which is 45 days later, so I'll talk about that in a second, all of a sudden I get a bill saying, well, this $2,800 are denied charges. So at that point in time, I have to go and change it from owed from the insurance company, from the individual. It's part of the archaicness of our system, but it's also the way under business billing that we have to do it. So I do mention also,
I'm sorry.
I just want to mention one more other thing, and this is mentioned on page 2. Current law requires claims to be paid within 45 days. Medicare is reimbursing us in 14 days. We really believe that insurance companies, whether it's the local insurers or other insurers or public health, should reimburse the hospital within 21 days, and that's what we've put in the contract, and that's what we're asking also from the legislature relative to the 2015 budget. But you're right, we don't know sometimes, by the way, if a person is self-pay. They might be self-pay, they might be Medicaid, they don't have their insurance, and then we have to go through all of that, and we don't get an immediate response as to whether or not people are eligible or members for Medicaid or MIP. We are working at it, but once again, it doesn't happen right away. So 5 months after the fact, we might find out, oh, this person doesn't have Medicaid. In fact, they're self-pay, and at that point in time, we start collecting from the individuals.
Sarah, just a couple of points, and just to follow up with what Alan's saying. Although the 170 was noted, Doesn't mean all of it's actually going to be written off. We are going to go back and go through every line item detail and really examine each write-off before we actually write it off. So this was what we initially determined, but it doesn't mean that all of it is just going to be wiped clean. So we're thoroughly going to go through that to make sure that it is truly non-collectible. And anything, we may discover that there may be some collectibles in there. So we are going to go back and really line item by line item look at that. The other thing I just wanted to mention that, as Alan noted, in terms of clinical documentation requirements required by public health, they ask for a lot of backup documentation because their system is not electronic, and so they ask for evidence of discharge summaries and op reports and things of that nature. But I have to say that we have made a drastic, really big improvement at GMH over the past several months with the doctors' help and working hard in cleaning up outstanding medical records, which we have now tied to the credentialing process. So, for example, now doctors, when they're up for credentials, we look at outstanding medical records charts, and if they have outstanding medical records, their credentials are not granted, and they must clean up their records before their privileges are renewed. And that is looked at every single month now at the subcommittee of the board. As you can guess, I'm not a real popular guy for that decision, but nonetheless, it has made a drastic impact. And many of the doctors have responded, and many of the doctors have worked hard. So we have made drastic improvements in that area.
I just want to add one more thing. It's like a tag team back and forth. If it takes a doctor 28 days before he's suspended, which we haven't done, but if it takes 28 days for them to complete their chart, that doesn't mean, it means that I'm discharged and 28 days later, 35 days later, 40 days later, the claim is released. It takes, under law, insurers have 45 days. It's taking typically over 100 days for us to get reimbursed. We have people who are being paid now for their wages and benefits, and if we miss that, we would be held accountable. But we're not getting paid, if we're getting paid, for over 100 days, and that's a real crunch that we try to survive. Thank you.
Thank you. What is the budgeted amount that the board approved for 2015? What was the amount, the total amount?
It's about
your budget?
$142 million total. And once again, as you pointed out, I believe you used the word $40 million. I'd have to look at the actual detail for what we look for reimbursement. But as pointed in here, it's not just the reimbursement for Guam Memorial, but it's the reimbursement that is organization, Guam agency.
Okay, so that's where I want to kind of get some clarification. So 142 is what they approve of that. And if I heard earlier, Mr. Chairman, it was 44 million is what you're asking the subsidy to be from the government? Is that?
From various sources that we listed to you that we just gave you.
And that's included in the 142.
Yes.
So if this doesn't pan out the way you guys are proposing it to pan out, then you're going to be short already because the amount that you budgeted was 142. Is that so? It's assuming that that 44 million worth is going to be approved the way you have proposed, right? I just want to get that understanding maybe for the others too, to be able to understand it better.
The budget that we put together is to put GMH on stable footing, to pay our obligations, to sustain the level of services that we provide now, and to continue the direction we provide now. If we do not receive this level of funding this year, then action will have to be taken at GMH. You heard the OPA saying she didn't understand how we continue to operate. And Alan and I pull miracles every day continuing to operate. Miracles are running short. And at some point, if based on the level of funding granted, then the hospital will have to be modified to accommodate the level of budget that is going to be appropriated. Whether that is restructuring the hospital, downsizing the hospital, whatever that may be, in order to accommodate the level of funding that will be appropriated. This funding sustains the hospital at the current level of beds, the current services we provide, the current services we plan to expand to, and sustains the level of services we provide now. So, in short, yes, this is the year that it's really time to make a decision to decide what type of GMH that you want for the island of Guam.
So your biggest category of revenue is from your, I think the vice speaker said it earlier, from patient receivables. Is that correct? So how
Yes.
much is that in the 2015? How much do you expect that to? 89 million.
From collections on receivables, yes.
And what was that category look like in in the existing 2014?
It's probably about the same.
And what are you tracking to collect? Are you tracking that 89 million?
We're collecting probably 70, 75 million. Now, once again, when we put together the 2014 budget, we made some assumptions. We had started the TEFRA rebasing. We had also put in the budget the correspondence to Senator Pangilinan and Senator Limtiacno that we wanted to have Medicaid and MIP reimburse us that cost. That was built into our collections. So that is also part and parcel of the funding that we're looking for 2015. I want to just add to something that Joe mentioned. I had a conversation today with NTT Data, who is our provider of clinical software, hardware, revenue cycle, and also financial systems, ERP systems, if you will. They were supposed to be here this weekend to install a server. They canceled the trip for non-payment. We owe them $200,000. They told me today they are not going to come and install a server. They're looking closely at converting our revenue cycle. They're not going to do anything with the clinical system until we give them guaranteed payments. Now, or they want a prepayment. I said I can't do that. But I cannot, I being the hospital, our clinicians, our staff, our revenues, our HR, procurement, and fiscal staff cannot move forward without a system, a support from NTT. And that's why it's really important that GMH is adequately funded. So whether it's NTT, whether it's our imaging equipment, maintenance person, or whether it's PeriPoint for pharmaceuticals and other supplies, we need to have a stable source of revenue to ensure that we pay them.
Senator, one point of clarification. The TEFRA rebase that we're requesting for, we're asking for retroactive to the last cost report, which would put us retroactive through this year. That's what we're asking for. Therefore, if we do get this, it will not only give us the rebase, but will give us retroactive funds, okay, as well, which then the local programs should have to match. So a lot of this money should come from based on our strategy if the TEFRA rebase comes, not only from Washington, but that's where you have to make sure that you consider adequately funding the local MIP programs to fund us at our increased rate, and funds are there to do that. And as you heard me mention at the beginning, whether or not that's successful, even though I believe I'm optimistic that we will be, whether or not that's successful, we believe that that's an issue that should proceed irregardless, because GMH needs to be reimbursed at that cost for those levels for the local people.
Okay, yeah, we've always done our part, and we're going to continue to do our part, right? It's just that now the 89 million of the receivables, I think, unless you're going to collect 10 million between now and September 30th, you're going to be short on that in collection, right? In what you forecasted the revenue to be. And so, I don't need a response, just to ensure that you're doing what needs to be done as well, in terms of if it's, and as you say, you're close to having that billing collection contract in place, and maybe that's going to boost it up. But you need to also do your part to ensure that what you set out to be in your revenue in that category is collected as well. Just to go on the pay raises, the first, you said that the first receipt you got was how much from the government?
Either 120 or 125 on February 14th. Yes.
But even after not receiving anything, you're still paying out that. And so that's a big concern for me, because when DOA was here and we asked that question, we said that GMH employees cannot be left out in this competitive wage act that the executive branch was going to implement. And we were guaranteed, we were sure that the monies from the government would be coming to GMH, and so you're confirming today that you have not received anything after that. And so how much is owed to the hospital from that point?
From February 12th through now, we just calculated this 2 weeks ago. It's $95,000 per payroll. So
what is the total?
If there's been 17 payrolls through the balance of the year, that's about $2.5 million. Yeah. And if I look at it once again, as of October 1st, it's $150 million plus. I'm sorry, $150,000 per payroll, which is the $4.1 million that Mr. Verga mentioned in his opening remarks. When you look at the actual legislative bill for fiscal 2014, you will see that Guam Memorial is not included in the list of agencies for the Hay Study implementation. And in my conversation, you say, I'm sorry, you were not included.
The allocation itself was not included. However, the assurances we got on record here during the hearing, Mr. Chairman, was that it would be provided to the hospital. We got that assurance. So has their efforts been, just like you have you've been asking them for the other millions that are owed, specifically to this, have you had that discussions with them?
I had one discussion with Adelup regarding that.
And the
It
response?
hasn't been, and once again, I was informed that it wasn't part of the funding, that we were not included in that funding.
Senators, we regularly communicate and meet with DOA and BBMR. In fact, that we regularly request what's available for GMA to draw down. We do it weekly. We'll be doing it again today. We do meet with Adelup, and Alan does go, and meet with Bernie and her staff regularly. The transfers have not been forthcoming, and as you heard, with 2 months left of this fiscal year, we're still entitled to $14 million more in 2 more months that we haven't received. We're really hurting for cash, and we really need it. So we have not received the funds even out you folks have allocated from those other sources, and we desperately need it.
Okay, and so we'll work with the chairman and ask the committee if they can pursue, because those were statements that were made on record here in this room. The final question I have is the heart project, the heart program. What does it look like in this 2015 budget? Is it the same as the 2014?
Yes, we're continuing to do the cardiac catheterizations. In fact, cardiac cath is a service we have targeted to increase. We would like to bring permanent cardiac services to Guam Memorial. In fact, I am in the process of negotiating with some providers a possible partnership. But we have actually budgeted for a cardiologist, a full-time at GMH this year to bring to GMH. But the actual heart project, will continue as it is now.
Okay, yeah.
If I can add one more thing to what Joe just said. Yes, we have a budget for the heart program, but also when you look at our budget for what is needed at Guam Memorial, what is needed for the patients who come to Guam Memorial, we have included in the 2015 budget 22 physicians, and that's to provide full-time care, the subspecialties that Joe is talking about, to provide the care both inpatient and outpatient to the people of Guam, so that they have that availability and that access at Guam Memorial. Thank you.
But Senator, that would be the type of service where if we don't get the level of funding we're asking for, we're going to have to take a hard look at and whether or not it can be sustained and continued. And those are the decisions that we'll have to make based on the funding we receive.
Sure. And so as you look at that, depending on what you receive, what GMH receives, what are your thoughts of departmentalizing, some of these services?
What do you mean by departmentalizing?
When you have, I see you nodding your head. I don't know if you have. Okay. Well, if you like for the heart project, if you have a separate budget, which you do now, but it's something that's run by that department.
Yes. In other words, we have a plan moving forward. Outpatient services are going to be centralized under one outpatient services director, and outpatient services we're expanding not only for cardiology, but we're looking for the other subspecialties that are very hard to find here in Guam. We've been talking to St. Luke's, and we're going to affiliate with St. Luke's to talk with them about possibly bringing some specialists here. But that is exactly where each department will have or does have their own budget. In fact, Alan does send out regular information, and we're looking to expand on that so that each department director keeps track of their own budget, and we hold them accountable for what they're spending. So this is part of the many things we have done. You talk about us doing our part. We are working very hard doing our part in a lot of different ways. But your question about departmentalizing is exactly what we're planning to do, because we'd like to establish cardiology as a permanent service at GMH.
Okay, great. Thank you very much. And I recognize you guys are doing your part as well, and your managers here. Finally, sorry, one more last question is, does this budget reflect the urgent care coming online?
Yes.
It
Yes.
does.
So that will be, I don't believe we set up a separate department for it, but we do have the staffing for it in the emergency department, and we have decided to, have them contiguous. And Joe can talk about that, but we did budget for the providers and the staffing and the support staff for that. So that's part of it. We also, as you see in the revenue summary, we have included a very modest amount of dollars coming from the gaming tax from the bill that you sponsored.
As you know, I'll refrain from talking about, but we've only received to date about $410,000 to date for urgent care so far. So we've realized less than we thought. I know you and I have had discussions about that. That will continue, but we're still moving forward with urgent care. In fact, we have an urgent care director. Belle's going to oversee that. She's establishing P&Ps right now. We're going to start recruiting clinicians to provide that, and we envision opening in the fall. In fact, I'd like to even pilot it even sooner, just to try to test it out. And the new location that we have for urgent care will be urgent care in the evenings when the public health clinics are closed and the other clinics on the island are closed. And then during the day when they're open, they will be regular outpatient services. For example, we just hired a surgeon that will be a hospitalist-based surgeon. And also we're negotiating, came to an agreement with a neurosurgeon who's also certified in neurology. So we will have neurosurgery and neurology, and as a service, but also as an outpatient clinic at Guam Memorial. So that's planned for the fall as well.
So I see, and I know what you're saying is that it reflects the budget in terms of what it's going to take to operate it. But what about in terms of the difference now? What impact it's going to have versus people who come into the ER using it as an urgent care, and now having it done, having them seen at an urgent care with much lower expense. Does your budget reflect that?
Well, we looked at the budget for, that's just part of the whole $89 million for collections. It's really difficult. We have the budget broken down between inpatient, outpatient, and emergency department. And so we would see a shift from emergency department charges to an urgent care, but it's not that's going to be that significant overall to the hospital, but it is part and parcel of that budget.
Okay. Thank you, Mr. Chair.
Thank you, Mr. Chair. Thank you both for joining us here today, and thank you to the GMH staff also for joining us. I'm grateful for the chair for having the two agencies that he's had today for hearings. The first was DOE earlier this morning, which is the lion's share of our budget. The second is GMH, which is the only entity in this government that has been given a going concern classification by our public auditor. And so for me, what that means to me is that these next 12 months are going to determine whether or not we have a GMH. I mean, that's basically the bottom line. And so the money, the financial situation, and the availability of resources for the agency to continue are incredibly concerning to me, and I want to make sure that we go through it with a fine-tooth comb to make sure you guys are able to keep going. The first thing I want to talk about was that $178 million write-off for the receivables. Now, a large chunk of those are the self-pay and uninsured, correct?
Yes.
Have all of those amounts been forwarded over to DRT so they can flag those amounts for every single taxpayer on this island in the event that they ever have to get a refund, that we're able to offset that 178 from potential refunds going out?
Appreciate that question, Senator. And actually, to answer your question, we are bound by certain So the statute of limitations is 4 years. So anything on our books for over 4 years is going to have to be written off.
What statute of limitations is that exactly?
There's a credit law that dictates that we cannot
Is
collect
that a
it.
federal law?
I believe so, yes.
Could you? I really need to know what this law is
I'll
because
get-
I've never heard of any law in the books that sets a statute of limitations for hospitals. And so I'm curious. I mean, if it's a local law, right now the statute of limitations on income tax is 10 years, GRT is 7 years, property taxes is 30 years. You know, so for the hospital to have a statute of limitations on collections at 4 years, I'm very curious where that's coming from.
And we'll follow up on that. You know, the interesting thing is that as I shared with you, and I have the information here that was presented last night to the board. When we have $251 million on the books, and of that, 170 million, let's say, is going to be written off. It's not written off in entirety. First of all, if you remember back in March, we submitted information to DRT to add another $55 million of receivables that will be covered through garnishment. In our negotiations with the collection agency, we are saying, if we receive money from garnishment, that's great. I can give you an example. I have a patient who is $18,000. We received $2,000 garnishment. I still have $16,000 left to collect. But at the same time, we are going to take that $18,000 or $16,000 and take it off of our books and give it to the collection agency. So they are going to continue collection efforts on it. It's just that we will not have it on our books because it's basically uncollectible.
It's a doubtful receivable.
Right.
But just so long as those are all going over to rev and tax, because you know we provision $120 million a year for tax refunds, you know, and so if we're having this many unpaid GMH bills, you know, I mean, we've got to be offsetting a significant amount of that to refund amounts, and that's money that will go directly to GMH because we already provisioned for that in the budget.
I understand that, Senator, but actually, if you look at our history, we are only getting between 1% and 2% of the refunds. So of the $120 million that you are budgeting for refunds, we might get $2 million. In fact, I think year to date we've received $3 million. The big bulk of dollars were received in 2012 when you had your bond financing that allowed the refunds, and then we received a significant amount of money. But right now it's under $3 million a year. We did budget that. That is a separate line item as a revenue source, but nonetheless, it is not. Just because it's $120 million means that we're going to get 50% of that in collections.
Yeah, and probably maybe the way the math works out is somebody's bill might be, like you said, 10 grand, but they only have a $2,000 refund.
And if I'm managing my
Or they may have no
Or
refund.
maybe they have no
Yeah,
refund.
I might be saying I don't want to have a refund at all, so I'm managing my withholdings during the year, so I don't owe any tax, or the government doesn't have any refunds due me. I mean, if I prefer having the money myself versus waiting for a refund, I prefer having just balance even. So I can't rely on GRT as a source of funding for paying down our self-pay and uninsured.
Okay. I think that maybe 1 or 2%. We gotta sit down with DRT and figure out exactly why it's that low, because it should be a little higher than that, I would think. I mean, if someone is uninsured self-pay, you know, they're going to the hospital, unless they are completely indigent and they're not working at all, which of course is some, but if they're working even a little bit, they're getting an EITC, which is another $50 million on top. You know, that makes about $50 million worth of the entire refunds that we pay out. So, you know, there has to be a much larger offset. Otherwise, I'd be very surprised if that $50 million in EITC we pay out, you know, is not going to the hospital, because technically the hospital would probably be the first place that the indigent would go to. So that $50 million, a large chunk of that, should be getting offset to GMH receivables, unless they're just not going and getting medical attention, which I would find to be very unlikely. So we need to work more closely with revenue tax, because that's not really adding up for me.
Or they could, Senator, be that a lot of these people maybe, you know, end up owing revenue tax and aren't getting refunds. And so I'm not sure what percentage of folks that, I mean, we are sending this stuff to DRT, but what we're getting back is only really a fraction of the total cost of what we're sending them. So, you know, I'd be interested in hearing what they say about folks that we've sent there, just picking up some names at random to see were they entitled to refunds? Did they get refunds, or did they owe rev and tax?
I think I can use the most recent set of refunds from about a month ago. $6 million, I think, was refunded. I think our total receipts were $330,000. Once again, that's just about 2%, or I can't do my math too well, but it's pretty low overall. 5%. Right. I'd have to look for sure on that one, but once again, in our conversations, and when I met Mr. Camacho at DRT, we talked about just 1 to 2% typically being what we received.
My other comment that I wanted to make, Mr. Chairman, is that we talked about small miracles, and that's a small miracle you guys are keeping GMH alive. I think it's a huge miracle that we've appropriated $20.7 million. You guys have only gotten 6.6, and nobody is camping out down there in front of Adelup or sitting in the governor's office in his waiting room demanding the $14 million. If we've appropriated the money, if it was signed into law, it had to have had a fiscal note. The money should already be there. The misperception is that we come to the legislature, we say we need the support, but when we're appropriating 20.7 and you're only getting 6.6, we could have appropriated $2 billion and you only got 6.6. So there's a serious disconnect between what the commitments of the people are in this body with our appropriations and the actual follow-through of that commitment with the administration in actually dispersing the cash to the agency. Do you guys know where that $14 million is?
It's not for lack of our efforts, Senator. Alan could tell you regularly he goes and meets with DOA, with Bernie and her staff. We're constantly sending correspondence back and forth about what we're owed and when can we expect these funds, and we do meet with them regularly, and I was just told there's nothing available, and so it's not for lack of trying, so for example, I mentioned to you, I'll be sending another email down to John Pangolini and say what's available for GMH to draw down, and the response that we'll get is nothing at this time, or and so so it's not that we're not there all the time. In fact, we are there pretty regularly. We're regular visitors, both of us. And
I'm sure we could be there every day, and they'd get tired.
Oh no, I understand that.
But
What I'm saying is a miracle is that that the administration is not being held accountable for providing the funding to the hospital. The impression out there is that the financial position of this government is roses and romance, but you've only gotten $6 million out of 20. And the hospital is a going concern according to our public auditor. So where's the $14 million? Where's the roses and romance?
Well,
And so when you're a going concern and we're trying to figure out how to keep GMH open and we're trying to figure out how to get your budget to a place where we're going to be confident about that, when we're appropriating so much money and only pennies on the dollar are getting to you, how can anyone ever think that that's the legislature's issue? We've done our part. But even for me, that's not enough. When is somebody going to hold the governor accountable for getting the money to GMH? When? Or is the plan to sell or close down GMH? And I like to know that plan so that we don't go through this whole rigmarole of, budgeting and putting people through all this kind of emotional upheaval of whether or not there's going to be enough money. Because if that's the plan, then let's just be upfront with what the plan is. But you can't appropriate $20 million, only give them 6, and then expect the hospital to kind of figure out how they're going to survive. So that's my spiel on that. I do want to talk a little bit about some of the details here in the budget. Some of the things that kind of jumped out at me. I was going through the budget digest here, and there's some disparities that I wanted to get clarified. One of them was when I look at salaries and increments, of course it goes up because of the hay adjustment. But when I look at benefits, they go up as well, but they go up at a rate that is not proportionate to what I would anticipate it going up at. Like for example, on the nursing division, we have salaries going from $21 million to $24 million, which is a $4 million increase. But then on the benefits column, benefits go from $7 million to $11 million, which is also a $4 million increase. But what are those benefits? I would assume that if we're looking at the 30% retirement fund contribution, 30% of $4 million is 1.2. So where's the other 3.8 or 2.8 coming from?
I would have to look at the
break out benefits, you also break out medical and dental. And so I'm just trying to, and the reason why I'm asking is because when I asked the same questions to DOE just this morning, they basically came out and said, we make the worst case assumption that everyone's going to go for the most expensive insurance option, which isn't the case. It never is. So they're inflating their benefits budget request. And that's kind of, that's become the practice of late within our government throughout the agencies. Everyone asks for this much, they can get that much. But if we operate from a position of trust, where ask for this much, we're going to fight to get you that much because that's how much we're going to make available, then we're not going to be second guessing everybody's numbers. So I'm assuming that this benefits number here is probably a worst case scenario inflation of, well, it can't even be the medical because that's separated out. I would like clarification as to what that is.
Yeah, coming back to, and I'll provide that information.
But DOE made it very clear they were just inflating theirs.
And
And that, after going through the numbers with them this morning, we found maybe about 20 million that was just built in to cushion, And so as we go through this whole process and we're trying to figure out how to keep the hospital going, I need to get to the hard numbers.
That's fine.
So
If I can comment relative to the medical, when I did that for medical and dental, I did it individual by individual based on what their current coverage was. So that went, and then you make certain assumptions for new employees coming in. But in general, it's based on what we have right now.
Okay, so the medical
And
and
then
dental
we did receive direction from BBMR as to what to budget for that. As far as the retirement, I'll have to take a look at it. But I do want to come back to what, if I can for a moment, to what Mr. Verga said. The payment of it's actually 30.03%, not 30.09 in 2014 for the retirement fund. I provided a misquote for Mr. Verga, so I apologize for that. But as we look at what our costs are to balance our revenues needed to balance the budget, we found that we were $5 to $7 million short based on what we were receiving, even assuming that if Medicaid and MIP fully reimburse us at cost, that we were $5 to $7 million short. The only way we could balance it was to ask the legislature to reduce GMH's requirement to fund physicians and other highly paid individuals at their actual contribution, which is a 5% corporate match. For example, if I'm making $100,000 a year, Guam Memorial is paying $30,000 to the retirement fund. I only get $5,000 credited to my account. And if I'm gone before 5 years, I don't even see that. So that $30,000 is going to the retirement fund, and we're just saying this total savings to the hospital is $5 to $7 million. Once again, to be fiscally break even. Thank you.
I agree. I mean, one of the things that I've been looking at is how we've built in this unfunded liability into all of our personnel categories across the board through all the agencies. It artificially inflates all of our personnel costs. We should extricate that and make it a separate appropriation in the budget, unfunded liability appropriation. That way we're getting a hard number on what personnel costs are across the government to include GMH. And that would really help agencies like yours where you're bearing the brunt of that cost out of your own pocket. Another question I had, though, just pouring through these numbers here, was, for example, on the nursing division, you increase your FTEs by 46, which is fine, but your overtime, it barely budges. And so, it barely drops. And I would expect that as the FTEs go up, we should be seeing a significant decline in the overtime. So if we can get something more firm on that.
And actually, that's a very good question. And certainly, when we look at the distribution of the nursing FTEs, we did budget additional FTEs. But there were other FTEs that I did not budget because I could not. If I have a nurse right now who is receiving, let's say, $10,000 of overtime, as we budget, and I have 10 nurses earning $10,000 of overtime, I did not put 2 FTEs into the budget. I just said, well, we have $100,000 of overtime, and we're not going to budget the people. I mean, so it's a budget. I didn't want to put new FTEs in and still keep the overtime based on what we're paying right now because there's no assurance. And if we talk to human resources, we talk to nursing, we have a very difficult time filling nursing positions. So we are keeping that at the overtime budgeted, and once again, with the hope that we can recruit those people.
Senator, there are some reasons for that because a lot of the nurses where we're short are specialized nurses. They're like ICU, OR, ER. Nurses don't come out of school and are an ICU nurse or an ER nurse. They have to be. It takes time to train. It takes about 6 months to train a nurse that comes out of training, even that has med-surg experience. And I guess I can call Joe up and ask. But on the average, we now have a program where we're rotating nurses, backfilling them from other areas to train, and then filling like the areas of med-surg that we could more likely fill with those nurses. But it's like the critical care nurses for the ICUs, the med tele units, the ORs and the ERs that are the more critical, difficult to find and to train, and it takes time to train them. So a lot of times what you have to do is almost double staff.
That's
to
fine.
train these
You know,
nurses.
you guys are the professionals to know how to figure out what you need to hire. All I'm saying is, if we're going to increase FTEs, let's try and work down the overtime number. And if you need to go with even more hires, do it, because FTE is time and a half. You know, so if we're still having a $4.6 million overtime budget for 2015, I mean, that's like kind of saying, yeah, we know we're going to overspend, and there's going to be those occurrences where we just need to do it. But I think that if we can do more hiring for those positions as needed, then that'd be a good thing. But maybe something to balance that out with will be the impact of the new hospital. You know, because that's a whole new topic that I'll get into in just a second, because I don't think you guys factored that into the budget here.
I'll disagree with you on that one, but I look forward to that conversation.
Yeah.
Sure. The other thing that kind of jumped out at me here was, you know, nursing division, very, very important, but the equipment budget went from $800,000 in this current fiscal year down to $300,000. So you guys are actually cutting the nursing equipment budget. I just want to make sure that's accurate.
Say that again?
The nursing budget for equipment was $800,000 in 2014, and you're dropping it down to $300,000 in your 2015 budget request. That's a $500,000 decrease.
We'll take a look at it. It could have been that we had some equipment, or we have volunteers that buy us equipment for various things, and it could be that we just determined that we looked and see where we could keep it as low or cut as possible. That may be one of them, but we'll take a look at
Okay,
it.
I just want to make sure, because nursing is very important. I want to make sure they have everything they need.
Can I add to that?
Sure.
The total initial request from our department manager was over $12 million. Now, in order to get a balanced budget, we have to include the appropriations for the capital. Now, so we have included $4 million in our capital budget. So, you know, we look at we prioritize our capital expenditures based on need. So even though it might say nursing is down $500,000, overall we're saying we have $4 million. And if there's an urgent need for this piece of equipment here, or that piece of equipment, or diagnostic equipment, we will make that decision. We move dollars around. But once again, $4 million is what we asked for capital expenditures.
Yeah, this subject was actually brought up also in DOE, and I understand that it's a budget type of way of doing things, but I'd like to get a clearer line of connection between, you know, what's being spent at the top side and how it's actually getting down to the service side. Like, for example, on DOEs, they were spending so much on central operations and almost nothing on the schools, and they were saying, well, it's going to trickle down to the schools, and I'm like, I got to see how that connects.
We can provide you with
So,
the details,
okay,
Senator.
that'll be great. What is the professional support division?
That is a division where the allied health professionals, you know, pharmacists, the rehab folks, the social services, you know, respiratory, radiology, those types of folks.
Okay. Because on that one also, we're increasing the FTEs by 14, and yet the overtime budget is going up by 600,000. So I'm like, if we're hiring more, why is overtime also increasing? You know, so that's just something that needs to make sense with me on the budget side. This category, I think across the board, we have that problem with the benefits, so that needs to be looked at across the board in all the category items. Operations division, what is that?
The ops division is like the facilities management, the housekeepers, the security guards, you know, all the supports, the ancillary services that go with supporting, you know, operations throughout the hospital.
The capital outlay budget for that one goes from 1.9 million to 6.4. That's
Yes, there are many significant capital needs in the facilities that have antiquated. You know, we need to replace our chillers. We need to replace our electrical panels. We need to replace our water tower. I mean, I'll give you an example. I mean, and I can ask William to come up and talk about capital. You know, we have a CIP committee that regularly goes over and tries to prioritize needs. But There are some significant capital needs, and I think we boiled it down. I think the number initially came out, like $12 million, and we boiled it down to like 6. So, really, what are the priority projects?
But this is also one of those areas that basically is providing services to all the divisions throughout the hospital.
Those, in other words, we
But
can't,
it's just
without electric, without air conditioning, without, that types of thing. Maintenance, fire doors, fire systems, all of those types of things.
And that's what kind of complicates this when we budget it this way, because then we're not able to see big picture-wise how much money is being spent for the total operation versus how much is being earmarked specifically for divisions. And one of the reasons why that concerns me is just technically when it's drafted up this way, then it can only be spent that way, and it requires the benevolence of management to make it trickle out elsewhere.
Is this what you're looking at, Schedule F?
I am looking
Capital
at
outlay?
You might have just a total, but
The
the
budget
actual
digest.
detail that we have here.
Because we have all the detail here, and in fact, we can give it to you and give
Please,
you more.
yeah, we got that from DOE, so that'd be great. If we
Yeah,
could,
please.
see the line
Yeah,
items.
we have it.
That's every budget packet that you have.
Wonderful.
So we have
You have that information. And if you need more, just let us know.
Okay. Administrative division. That's you guys, right?
I'm fiscal, I'm sorry.
Okay, not you.
You can direct it to him.
Administrative division. I actually was very curious about this one because your FTEs go up by 7, but your salaries drops by 1.2. And I was wondering, how do you hire 7 people and salaries go down by 1.2 unless Director Verga is taking a very generous pay cut?
Entry-level positions.
Okay. So, but that also would require that we're having more senior people leaving.
Well, since I've been there, I think the administrative division has gone down at least 6 or 7 employees that we have not replaced. And so these were people like that had titles like program coordinators, analysts, things that we didn't need. And so what we needed were more like clerk typists or secretaries and things of that nature, which really brought it down to a lower salary category.
Because for this current fiscal year, it's 2.8 million, but for next fiscal year, you guys are only requesting for 1.6.
But you have to understand also, Senator, that I believe we did add another department. We have a compliance department that
Yes,
has shifted
that's-
costs away from administration. Also within administration, we had the quality improvement, which has moved to a different
So you guys have
department also.
decentralized.
Yeah, there's another department that used to be part of administration, which is now a separate department, and that's the Department of Compliance, and there's nurses, and there's other folks in that department, and that's, so we kind of shifted. That's not administration, that's really more operational support. They're clinical people, they're clinical support, they do continued stay reviews, they do all our performance improvement, joint commissions, CMS requirements. So what we did was centralize those quality and safety folks, because they were in administration, so to say.
The other thing that I wanted to bring up was I saw a letter from the Attorney General. Apparently, the AG's opinion is that hospital security should have also been included in the law enforcement pay adjustment. Have you guys included that in your budget request?
No, we have not, because that would be another liability that we'd have to include, because we've been arguing against that, and we have a civil service hearing pending on that. The hospital's position was that those folks, the intent of the law was not to include those folks as law enforcement officers, and that's been the hospital's position against it. The AG came out with that opinion, which is exactly that opinion. I'm going to speak to our attorney, but we're scheduled for a civil service hearing on it, and if we lose it, we'll not only have to give the raises, but we'll have to give this back money, which is going to amount to about $500,000, and it's not included in the budget, which we're then going to have to come back and make a request. I'm not sure if that was the intent of the law, and Speaker Cruz, if you can maybe make a statement on that, that would be very helpful for us, because we are about to go to civil service with it.
You were never supposed to be able to even hire that whole set. At the very end of the last administration, I questioned the fact that the hospital hired 21 security guards. And when the new administration came in, rather than do anything about it, you've kept them on now for 4 years. So I've been saying since the beginning that, one, we never intended it. At least I didn't. And two, I don't know why the hospital, when it's outsourced everything else, decided that this was something that it was going to take in-house.
When I came here, that was one of the things that, of course, I inherited was that those raises were given or were not given before, and I guess that was when this class action was, was decided to be filed. So if we do lose this case, it might be something we may have to look to outsource as well. But for the here and now, we've been taking the position that they're not entitled to it, and we're going to civil service with it. So if we do lose it, that, like I said, that's going to add about $500,000 in retro pay to these folks.
And in addition, it'll cost another $250,000 every year.
That's right, not to mention the actual effect on the payroll, which it would add another about $250,000 to the payroll. So you're talking about another $750,000 if we lose this particular case.
So, just overall, it took my staff a while to pull this digest for me, so I'm not quite sure how accurate it is. I want to make sure it is. We're looking at a $10 million increase in personnel costs, but a $26 million decrease in operations costs, with the bulk of that coming from miscellaneous, and a total appropriation going from 135 for 2014 down to 125 for 2015.
Well, first of all, last year, if you remember, for our 2014 budget, we included $20 million for payments to vendors. So that's no longer an issue with the funding that we received from the governor and from the legislature, from Healthy Futures and from Compact Impacts. We appreciate that, the financing that we completed. We did not anticipate payments to vendors in our 2015 budget. Perhaps we should, since we now owe $14 million to the vendors, and that continues to raise. But that's why it's very important that we receive the remittances, the reimbursement at our cost, whether it's from Medicaid, MIP, or for Medicare.
As a reminder, as you know, out of the loan, we received $14 million proceeds, which we know didn't cover the whole 22 that we owed anyway. So that's the reminder of that.
So this 125, we might need to modify that upwards by 14, depending on how the current fiscal year turns out.
Well, the actual budget, Senator, I believe is $142 million, of which $4 million is for capital expenditures. So if I'm looking at the budget digest at the top and the second page too, that I show $89 million of collections from insurers, appropriations for $44.6 million, federal funding of $3 million, and $4.9 million from other agencies, including from collection agencies, DRT, for $142 million. So we have 2014 budget was $143.8 million. We've reduced that to $141.9 million. But once again, we have additional costs this year due to the increment to Hay study, which together are significant costs. We also have additional costs, as I said, for 22 physicians that we are including in the budget to ensure the quality of care. Thank you.
Yeah, okay, yeah. The vice speaker here is showing me the updated budget digest, and it's more accurate.
So you do have those, but I think all of you have those, right? Correct?
Yeah, so it's $2 million less than this fiscal year. That's assuming you get your $14 million.
Once again, it's very important that when you look at the funding that we're requesting from Adelup, it's a three-part request. I'm sorry. The first part are the existing appropriations that you have, even though now I see that Healthy Futures has been reduced by $1 million to make it budget neutral. We would have hoped that we get the benefit of more pharmacy funds and also the Healthy Futures at historical levels. But we also have the appropriations for public health. And we have the other agencies that we've identified in this letter.
So you have 100.
When we talk, I would just say, public health is not only reimbursing us in 2015 at cost, but as Joe and I have both mentioned, we're talking that if we get rebased back to October 1st of 2012, we're talking at about $5 to $10 million per year that should be appropriated in 2015, because it'll probably be a 2015 event when it happens. And then the third part is the additional reimbursement that we're talking about, that Joe has made an ardent case that we need to have something to provide some relief for the $27 million to $30 million of care we're providing to the self-pay and the uninsured seek care and we have to provide care at the hospital. If we're only getting $3 million and we're incurring $30 million, we cannot continue the way we are, which is why we are seeing a big increase in our request for the Gov Guam and the legislature to provide that support for the self-pay and the uninsured.
What percentage of the total revenues is coming from the actual insurance companies paid by insurance
Well, if you look
companies?
at the second page, the assumptions of the revenues, you can see that $89 million is coming from the 3Ms plus commercial and self-pay. So that's what we're budgeting as far as revenues for this upcoming year. Of that, the 3Ms are $60 million, so that's probably 2/3 coming from the government programs, and the balance is coming from self-pay and from the commercial insurers. Once again, we are in negotiations with the insurers in order to improve the reimbursement that is very historical based on outdated fees and outdated methods.
Now, of that 89 million, how much is the new hospital's market share going to be when they open up?
That's a very good question, and that's been a question on the board. When we built the budget, we assumed that our inpatient volumes would reduce 10%.
10%.
Now, so what number is right? I didn't have a crystal ball.
Yeah.
And
I like being
Joe and I
safe,
have
though.
talked about
When
it.
we're a going concern, I like being safe.
You know, I tell you, Senator, I really, this is a conversation that I really don't think that anyone can answer. I think we're going to see maybe volumes drop a little bit. I do not think it's going to sustain. I think ultimately all these volumes are going to come back to GMH because these are people that are the complexity and volume of which, and the majority of which are government programs and self-payers that I just don't see being taken care of on an ongoing basis at the other hospital. I see the other hospital, if anything, looking for specialty services. I mean, they've openly, I really don't know what type of services they're going to provide. So, maybe, but from what I've heard, they're not going to be a trauma center, but they're going to provide other services that GMH provides now, which is basically competing with us. OB, internal medicine, med-surg, pediatrics.
Which means they're going to eat into your market share when they offer those
well,
services.
the only thing they're eating into right now is my staff. I'm losing staff to them. Okay, so
That's the beginning.
which is another whole discussion. Okay, quite frankly, you're going to be hearing soon that we're going to be affiliating with St. Luke's in the Philippines, which is to possibly bring not only education programs but physicians and other professionals who meet the criteria and who are U.S. trained, and they have a good number of them. These are like subspecialties like gastroenterologists, rheumatologists, pulmonologists that we don't have, that we would then have access to on a rotating basis. So you'll be hearing more that this is really exciting and offering more choice for the people of Guam.
Can I just give you an analogy of what's worrying me here? When we had Townhouse, everybody knows Townhouse, right? Everybody went to Townhouse. When Kmart opened up, Townhouse closed. And if Townhouse sat down and said, oh, Kmart's only going to get 10% of our market share, we all know how history turned out then. This new hospital is going to be the Kmart of hospitals because they're brand new. It's just the impression. Everyone's going to want to go try the new thing. And we got to go survive for the next 12 months with this new, shiny object to compete with that's going to be eating into our market share because they're offering the same things we do. We already only get 40 cents on the dollar for Medicaid. 40% of every Medicaid dollar goes to GMH. How much less now for Medicaid because they're going to be going to the new hospital? How much less on insurance customers because they're going to be going to the new hospital?
Well, there's also,
and I know that you guys factored 10%, but I think that's a little too conservative. The reason why I need to ask is because we cannot expect the hospital to survive by being conservative with that estimate, only to be surprised and to have everybody say, what are we going to do come January? And we've already budgeted in October. Once we budget in October, guys, there's no way we're going to be able to find $50 million to make up for some kind of shortfall that the new hospital is going to present. So that's why it's so important that we have that number spot on or even over projected, so that we're not going to have the hospital close down in January, February, March.
I understand what you're saying, Senator, but let me allay some of your concerns. First of all, in order to be eligible for Medicare, Medicaid, and MIP, the new hospital is going to have to be certified and accredited. It will not be accredited and certified when it opens its doors. It's going to take time. So therefore, they will not be eligible for those funds. And they also won't be Joint Commission accredited when they open their doors either, which will mean they will not get deemed status for a little while. So it would be at least for a year that we're going to be operating. I just don't see how they're going to get their revenue unless the legislature is going to make some special provision to allow them the revenue, which I think would be ludicrous. I don't see how they're going to be eligible for that. So what are they going to be eligible for? They'll be eligible for insurance pays. They'll be eligible for self-pays. Can they survive on insurance and self-pays? Well, even if they take every insurance patient we have, that's about $28 million, which is not going to happen. I see some shift going on. I see, by and large, the bulk and majority of patients continuing to come to GMH, and if anything, GMH flourishing and the need for GMH services expanding. So for the next year, it would be irresponsible for us to say we're going to cut out 30% of the revenue because we're going to reduce 30% of our services because we expect 30% to go over there. I don't think that's going to happen. It would be irresponsible because, again, knowing what I know about the hospital needing to be certified and accredited to be eligible for the 3M funds, it's not going to happen when they open their doors. So it's going to take some time for them to do that. And what their plan is, I can't tell you. I can only talk about GMH's plan and our plan for the future. And our plan for the future is solid, that we're laying out. It will continue to care for the people of Guam and maintain the level of services we provide now.
The other 60% of private medical service providers here in Guam that take up the Medicaid money, are they all accredited by those same institutions? How are they getting 60 cents on the dollar of our Medicaid money?
Those are community providers are different than a hospital-based designation, which is why we get a higher reimbursement rate from CMS because we need to be certified. Not all community providers have to meet CMS standards and regulations, but and in order for them to be reimbursable, but they don't receive a quote regular inspection, regular certification. Surgery centers do, day hospitals do, and certainly hospitals do. If you're Joint Commission accredited and you get deemed status, that meets the requirements for Medicare. If you're not Joint Commission accredited, then you have to undergo a full-blown CMS inspection. GMH is both CMS and Joint Commission accredited. So, and that is a major, major difference under U.S. domestic standards as opposed to international. So, I mean, I can get into this, nuances, but operationally, that's why I just don't see that happening.
So then on the 3Ms, on the Medicaid and the Medicare in particular, you don't see the new hospital getting any of that market share?
I don't see, I mean, the patients can go there, but they won't receive the Medicare and Medicaid and MIP money, so they can go and pay themselves. But to be eligible to receive any of that 3M money, you must be CMS certified.
And how long does that process take for CMS?
That process can take anywhere from 6 months to a year.
So they can get it in the next 6 months?
Theoretically. And that is if all services are established. And then they have to undergo a full-blown survey and meet all the conditions of participation. They must be in full compliance with all the conditions of participation. If you're even out of compliance with one, you do not get certified.
So we're basically going to hope that they don't have all their ducks in a row, and that's what we're going to bank on when we come up with.
No, I'm not hoping. I know how long it takes to get certified because I've accredited and certified hospitals. You don't do it when you just open your doors. So, in fact, you don't have it before you open your doors either. So it's going to take time. It usually takes hospitals about a year on the average, Senator.
I'd be comfortable if we weren't a going concern, but because we are, for me the conversation changes. Every single risk element now on the table has a heightened concern profile for me, because we have people who work at this hospital. We have all these employees who are here today and their families, and if we're going to say we don't think 6 months maybe, worst case scenario, if it does actually happen, we're going to be in a lurch because we've already budgeted without factoring in that worst case scenario.
Let me respond to your question, because I can't be on both ends of the spectrum. Either I'm making some logical assumptions relative to lost business, or I'm going to say the sky is falling and I don't budget 30% of my staffing and my operating costs. I can't give you two budgets. I have to submit one budget.
No, but you
So-
are. Your benefits are inflated, but your risk assumptions are deflated. And I'm saying that has to be reversed.
But
Maybe
I
the
would-
benefit side can be lower so that we can properly account for that money, but we need to fully factor in the risk profile.
Well, I'll take a look at the benefits. I wouldn't agree with your comment that we are overinflated on the benefits. I'll give you that information. But coming back to the original comment is that we are assuming that we will be affected. How much? We have no clue. But rather than my submitting a budget for 500 FTEs and then saying, well, now I have to go up to 900 and it's above budget overage because we said we were going to lose all this business that didn't happen. We are conservative and we have it budgeted, but we can always reduce and not fill positions, and we staff based on volumes. So we are budgeting it here, and we will have the capabilities as we do right now. We don't fill it. I think we have 175 vacant positions, but that's because we can't recruit the people. And then one other thing, as we talk to the insurers and we talk about our fees, we have said we will be competitive. We have a 50-year-old infrastructure, current wages but not old infrastructure, but we don't have the embedded cost of a totally new infrastructure that's going to build up our costs. We can be competitive with our fees, and we will be competitive so that the insurers say, we want to have the care done at GMH because it's a fair fee, high quality, and good outcomes. So what does that mean? We don't know.
The other essential component to this, Senator, are the other physicians. I mean, many, where the physicians' loyalty lie, and many of our physicians have also indicated their loyalty to GMH and the fact that they're staying there. The fact that the new hospital requires them to have malpractice insurance is a big liability for the other facility. I mean, there are things that, again, I just don't see, I could see, complicating. And as I said to you before, we're going to have to remain somewhat flexible and nimble. I mean, if we do see a drop in volume, we'll have to monitor it and see how long it lasts, and then we'll have to make adjustments, okay, as we go along. But we think that this is more than responsible. I do not see the need for GMH's services drastically being reduced in the next year for any length of time. Let me put it that way.
And once again, since, dollars and cents are important and all that, we have an accrual on the books right now, $15 million for annual leave and sick leave that is due. $15 million. If, in fact, I lose all of these people because they're not going to be working at GMH, and Joe talked about our staffing issues that we have right now, then all of a sudden my benefit costs are going to be that high because I have to pay out to all the employees who no longer are full-time at the hospital and do not earn those benefits, and they get it as part of their severance, if you will. So once again, it's kind of a balancing act. We are staffing based on acuity and census, and we continue to look at ways to maximize our productivity and to make sure that we have the correct staffing. And if there is downsizing that happens, then we'll be very judicious and aggressive in how to do it, because we cannot. If I'm losing $3.2 million a month right now, which is what I lost in June, I cannot afford to lose $5 million a month because of lower revenues and having a high cost. So I mean, that's where from a management standpoint, that's what you're asking us to do, and that's what we do.
Also, Senator, one other thing you have to keep in mind, their reimbursement rate is going to be different because their cost structure is going to be very different from GMH. GMH's expenses are much higher and different, and are going to be different than theirs. They are not going to receive the same rate that we are under the 3Ms. So that's going to be another factor that they're going to have to consider and deal with. So these are all other complicating factors, again, that I just don't see the need for GMH's services drastically reduced for any length of time.
Okay. But and the reason why I'm very, very concerned is because we're all in this boat together. And if come February, March, everything does not turn out the way we are all anticipating, or it's all being shared here, we're going to have, 1,000 people to answer to in terms of employees, plus their families, an entire history and legacy of medical care up at that hospital, an entire island community, and That's a really heavy load for me to bear.
It's 180,000 people who are affected, plus people who come to Guam Memorial for care.
I'm talking about strictly speaking with respect to the institution that we're all trying to keep alive here and actually succeed. And so, my outlook on the future, we're a going concern. We're bleeding $3 million a month. If it goes to 5, it's even worse. We have a new competitor that's going to be opening up. We need to be very, very cautious, and if it means appropriating even more money to subsidize it, while all of those variables work themselves out and the fluctuations until we can find a baseline, that's something that we need to put in the budget now, because we can't come back in February, March, and magically come up with $30 or $40 million. That's not going to be able to happen.
Senator,
So I just want to know what the hard number is now, and make it very, very clear that we asked for it, so that if we ever get to that road in the future, my conscience can be clear.
I don't like to quote politicians, but I will quote an ex-president. I personally am not afraid of competition. In fact, I like it. All I say is bring it on, because I know that GMH, in terms of it's patient outcomes that's going to drive where people are going to want to go, and in terms of patient outcomes, I have every confidence in the patient outcomes and the staff at GMH, as opposed to any new hospital just opening their doors. I mean, we can put our core measures right now. We benchmark with the best hospitals in the U.S. Okay, so I mean, these are all things people are going to want to go where they get the best care. They might like initially, these are nicer 4 walls, but when you look at their staffing levels being unbelievably low, the lowest I've ever heard of it in my career, as opposed to us maintaining decent standards, you look at there's going to be major differences in the two facilities, and people are going to make a choice where they're going to want to go, and ultimately they're going to want to come to GMH, and that's my guarantee.
Thank you, Mr. Chairman. Thank you both.
Thank you very much. How long have you been there now?
Not 2 years yet.
2 years this month, right? Or this
Next
next month. And the reason why when did we have the hearing at the hospital on the new rates?
On the which,
The new rates.
you were at the July 2013 meeting.
That was
No,
20.
that was September.
No,
No, that was July when
It was
the
July.
senators attended that. Yes.
it's been 12 months.
Mm-hmm.
12 months later, we still don't have the rates out. Is that correct?
They were submitted.
No, they
to
were
the
submitted to
Speaker,
the
and we were-
legislature.
And when are we supposed to be addressing them?
If you can, yes.
If it was submitted to the legislature and then it was withdrawn. It was withdrawn. They were working on, and the explanation, which was very reasonable, they were working on these negotiations with the insurance companies, and also I'm looking at what the new facility was going to offer. So they did submit it. It was withdrawn, and so we're still waiting for them to come back with some revised fee structures.
And my concern, Mr. Chairman, and both of you is, you say you're now in negotiations with the insurance companies. Unless my information is incorrect, Mr. Chairman, we've concluded the negotiations for insurance. The negotiations for Guam Insurance, which is 12,000 of us. I don't believe that they're going to be changing their rates on us now that they've made. If they were dealing with your old rates, they're either going to have to take a major loss, or they're going to fight you on any increase in the rates this late in the game. They submitted their responses to the negotiating team based on the rates that they thought they were going to have for the upcoming year.
Senator, they've opposed us. They're opposing us at any increase.
I understand, but if we had done something where they knew that there was going to be a 30% increase, then there would be a 30% increase in our premiums to address that.
And they were told that. We were going for a 60% increase at that time. And if you recall, that was what we were angling for, and we still are. And then we said, okay, we we would think about going down to 30%, but they had ample warning that we were going to increase our fees. So it's not like they didn't have any notice. And it's not like they didn't know. We had that hearing. We did withdraw the fees for now, for the legislature, because we wanted a chance to go back and talk to them about negotiating a per diem rate. But it wasn't that they didn't know. They did know. And so if they failed to put that increase in, now they're going to argue they're going to have to take a loss. I don't buy that at all, because that was their responsibility to put that in there.
All right, and as far as the insurers, you're saying that in your statement, you said the insurer's not adequately paying. Why is that? Is it part of your discounted program that you have with them? What?
I can show you average per diems for the last, average cost per day, if you will. And where here are my costs, here are my fees, because I haven't adjusted my fees for 15, 20, 25 years, and I'm getting reimbursed 90% of that. So my costs are here, and we have never raised our fees to be above our costs or adequately done that, and therefore that's why I say we're not getting reimbursed. When we talked to them on Wednesday, we said, I anticipate the insurers are going to be going from, I gave them numbers, let's say 29 million to 40 million. That's a 30% increase. And I talked about, and I presented that to them. Now, we're talking, I might be bleeding a little from the interchange, but nonetheless, we're going to be negotiating a rate that is fair for GMH to be reimbursed, not at cost, at a factor above cost. They want to be reimbursed based on Medicare rates. I don't have a problem with that, but not at Medicare. And that's part of the whole negotiations that we have.
The other reason why I'm, to say upset would be an understatement. When you first both came on, I made mention of the fact that I knew that since 4 years ago this month, there was an RFP out for collection agency. And 3.5 years back, that RFP has been sitting or was rejected, and you still don't have a collection agency. How much of the amounts that you wrote off in this 178 were written off because you didn't have a collection agency that could have filed and told the statute of limitations 3.5 years ago?
I can't comment, and Joe can't comment. I won't speak for Joe as to what happened 3.5 years ago. It took me 8 months to craft an RFP, including the documentation, and that's what we talked about. How can we relieve ourselves of the procurement rules and regs? I won't tell you how many conversations we had with council and with the AG's office as to how to structure this appropriately under GovGuam rules. It took that long. We submitted it to 16 companies. 3 companies responded. And the other 13 didn't because they could not, they were all mainland based, and they might have done a bang up job, but the difference in time zones was a difference. So in answer to your question, yes, I've held off referring a lot of the receivables. We did do it with DRT, but we didn't do it because I wanted to get this collection agency confirmed with different rules of engagement, if you will, to be more aggressive.
And you made mention of the fact that as a result of the huge bond that we borrowed to pay out tax refunds, the highest amounts of money that you guys received from garnishments from rev and tax was, I guess it would have been Christmas 2012?
Yes, $11 million. 11 or 13 million, I believe, yes.
That was in fiscal year 2013?
I believe so.
December 2012 would have been FY 2013.
Was that fall of 2012, November 2012?
Yes, it was right after.
Yeah, so that would have been 13.
And if I'm looking at the OPA report correctly, your lowest collection was in FY13.
From other sources?
No. Your operating revenue on page 1 of her report in 2013 2009, GMH collected in revenue 93 million. In 2010, it was 84 million. In 2011, it was 69 million. In 2012, it jumped to 85 million. But then in 2013, it dropped to 69 million. During those same 5 years, your operating expenditures were virtually within a couple of $1 million of each other for those fiscal years. But your collections dropped by about 25%.
That's the OPA's report. Yes, that. I have to see what she's counting as revenues, but if that's collections, including DRT.
You were given an opportunity to respond before this thing was published, right?
I received a copy of that, yes.
And you were able to respond to it.
I did not respond to it.
Well, I'm just telling you that looking from that, it's no wonder she reported, and Senator Nicholas keeps mentioning, whether or not it's a going concern.
It is a concern. It is a going concern, and both from the OPA and from Deloitte, and also from the Department of Interior, from the OIG audit that was done, they are all very concerned about what we're doing.
And to your credit, you've kept your operating expenditures, went from 103 to 99 to 105 to 105 to 103, and it stated 103. But your collections were all over the board. And the last one in 2013, the year that you got $11 million from the government in garnishments, you were down at 69.
$11 million for garnishments.
No, that's
But I don't understand, Senator, where you're going with this, because, the other we didn't have a collection agency, we do now. The RFP failed in the past because the RFP wasn't detailed and specific enough about what it needed to do. We're being responsible to bring these people on.
Why it's taking so long. Since you first came on 2 years ago, I've been talking to you about the fact that your business office needed to be upgraded.
And that's exactly what we've done. It takes time to get things done, Senator. You can't raise the Titanic in a year or 2 years. You can't set up you can't correct antiquated systems and things that aren't happening overnight. And I think we're at a point now where we've done a whole lot, and we're at the point where we have a billing and collections outsourced. You've been wanting to see that for a long time. We have a collections agency now. We've been responsible with trying to bring this on.
Is there a collection agency now signed?
No.
No.
They've had
So we'll just get that corrected, Mr. Virga.
No, we do. We are in negotiations to sign a contract
We've
with the
been in
collections
negotiations
agency.
for almost 3.5 years.
No, we have not.
I disagree.
That is incorrect.
Because
This is a brand new RFP, Senator. A brand new RFP that was recently responded to, that we recently just chose the new vendor. How long ago, Alan?
a couple months.
A couple of months ago.
And I asked them for a copy of the contract. Finally received it 2 weeks ago. I've modified it based on our negotiations, following the procurement rules. We identify a vendor, we negotiate with them. We've had 4 to 5 calls with them, and now we're in the process. Here's the contract. Here's the terms that we agreed. Let's finalize it. And I told the board last night I'd like to have that done by July 31st. That's the goal. But they did not respond to my email or from the last couple of days. But our council has it, and they have a copy, and now we just have to finalize it. But actually, in answer to your question, as Joe pointed out, we had to start the RFP all over again. We had to change the type, the structure, and then we have to go through the review, the selection, the negotiation, all of these things. We started this process back in February, and here it is July, and we still don't have a contract. And that's because it takes time, and we're doing it. But we are going to do it. That's what I promised the board last night and at the Finance Committee on Tuesday.
We have the vendors. The ink is just not signed on the piece of paper, which should be imminently in the next week or two.
The Vice Speaker where the Vice Speaker is going with this is we see a lot of these things unfolding and we're trying to get in front of it. We don't want to be caught behind it because behind it is already too late. And we talked about raising the Titanic. You're right, you can't do that overnight. But once we raise this Titanic in the next week or two, the huge iceberg of the new hospital is going to show up right there on the horizon. And that's why we're kind of bringing all of these issues up at once, because we're going to have to make sure that we're not trying to turn the ship too late. Because too late is too late for GMH, and that's too much to ask from everybody here today. So that's where the Vice Speaker is kind of coming from. That's where I'm coming from, and I think that's where we all want to go. We all want to make sure that we avoid that huge iceberg that's coming up from the water, and that's going to require us to be very diligent in how we're looking at all of the individual numbers, and also making sure that we're diligent in how we're truly factoring in that risk profile of what the new hospital is going to represent. And I just hope that the passion that we have here today to defend what we're talking about now is going to be the same passion that we have to follow through all the way over the next 9 months as that iceberg comes over the horizon, and we've got to figure out how to move this ship. Thank you, Mr. Chair.
Thank you. The committee will recess the budget hearing, and we will notify the proper agencies and provide public notice with a schedule for when we will reconvene the budget